want to recognize Dr. Doty. Not all program directors have the courage, I say that, have the courage and commitment to go public with that horrible sense of loss, shame, guilt, and confusion when one of their residents dies by their own hand. See, I know this because I'm involved in many things throughout this country where program directors are embarrassed and they're not going public. They're trying to cover it up. His sentence, "We must speak its name," embodies the urgency, the mandate of what needs to be done to bring this dark subject out of the medical closet. Speaking openly not only lessens the inner anguish, but it simply tells the truth. We should not have to whisper about or avoid the authenticity of how this young man died, right? We honor his short and accomplished life with the truth. And we give pause, reflect, examine, learn, and push forward with enriched attitudes and standards. So I said, thank you, Dr. Doty. Your email message extends way beyond your colleagues in emergency medicine. You're carrying the banner of former Surgeon General Dr. David Satcher, who prophetically stated in 2001, suicide prevention is everyone's business. Okay. I think on that note, I have got a few other slides, but I'm just going to stop and open this up for some discussion. Yeah.
I'm wondering what with your expertise in burnout and wellness, my kind of feeling about it and experience myself is that burnout seems to be a spectrum to me. I think every physician goes through it.
Yeah.
Whether it gets to a point where, God forbid, you're feeling this or need professional help is valuable for the person for the instance. So I've often said to a lot of the residents that you will go through burnout during your residency, and I think it's something you can learn from. You learn from what you put out there in terms of the signs of it and how you prevent it. So I just wonder what your thoughts about that.
Yes, no, I would agree with that completely. And especially the continuum, because it does come in different shades and in smaller and larger amounts. And it could vary with the service too, that some individuals might feel it more. And the other thing we need to remember, even though it's an occupational definition, if you've got other stuff going on in your life, and I'm just in the middle of assessing somebody who I just saw last Saturday, who I'm disguising this, but is in the middle of a major relationship breakup during her residency, and it got out by her just walking out one day. And this is not like her. She knows that that was unprofessional behavior, but she just thought that she was going to go psychotic if she stayed on site 1 nanosecond longer. Like everything just came to a head, that sort of thing. Now we'll get that all worked out, that sort of thing. But so as I said, that's the systemic piece of the burnout, but there was a lot of sort of burnout stuff going on in the residency as well. Again, it's something personal. So by alerting them to that, and then maybe it means too that whether you have any say over kind of even arranging vacation or a few days off or something like that. Like technically burnout doesn't go away with vacation, that sort of thing, but that's insidious. That's severe burnout. That's when it's probably been allowed to go on way too long. And I think that's one of the things that we're learning about this whole subject, which by the way isn't in DSM, but it's in ICD, is that we are learning something from it. We are learning more about prevention and just even what you're doing. You're using the B word, that sort of stuff. Okay, and I think by saying that too, you're saying like this is just part of doing business. It could also, I like the way you said too, you can learn from this. And we do learn from things that befall us, or we learn from stuff that sort of affects a colleague. And just sort of by reaching out to them or whatever, when they say thank you, to say, well, you may be, our roles may be reversed soon.
Yeah,
Sooner rather than later.
In residency, to learn from it, and because we do care about you guys, and there's a lot of people who are looking after that. And when you're done with training, there's less people who are necessarily looking at your well-being, other than your loved ones and people at home. That's always been a sign for me that when it starts coming to home, that's a big marker.
Yeah. By the way, you've touched on something just in what you said about when you were done training. I always tell sort of senior residents who are job hunting, be careful. Search carefully. you know, like in other words, it could be a very enticing job offer. It may pay well, it may look good on paper, but make sure you talk with some of the current practitioners there, and hopefully they'll be honest with you. But do they have rapid turnover? Is this a toxic place, but yet pays big bucks or something like that? That sort of thing. So very important to kind of pay attention to, you know, to the wisdom of mentors and things like that, and just chill a little bit and look at some other jobs.
Yeah, I was just wondering, I mean, you mentioned vacation. I think residents work 60, 80 hours, sometimes more, and get a total of 4 weeks vacation. Coming from Europe, I mean, 4 weeks vacation is a joke. It's nothing. I think you should have 6 or 8 or 10 weeks in order, particularly if you're such a high-stress job, you don't have time to recharge your battery.
Who do I speak to about that?
You're lost cause. So I'm wondering whether, I mean, there isn't something that we can do that is relatively easily done to inject a few more days off in between, rather than bunching them together once or twice a year.
Yes, yeah, that's a good question too, and it's kind of, you could call it at one level micromanaging, but sometimes when people really get to know themselves too, I've learned so much from my physician patients. They'll say, yeah, so I get 4 weeks. I would agree with you. You know, from a European perspective, this is absolutely ridiculous. But they think a lot of the things, the way we do business, is kind of nutty anyway, that sort of thing. But what people will do, some will say, I don't take it all at once, although I would really like to, because then I would really get a sense of being away, but then I'm not going to be able to work, you know, all those other weeks. So some will say, but I need more than 1 week. That doesn't seem to do it. People make statements like, if I'm able to change shift, or if we look at how the call schedule works, if there's some way that there can be sort of a day or two built in there. And other people kind of, who know themselves well, will make statements too about the importance of actually getting away from, like, their home, for instance. Even if it means going for a sort of weekend away or something with your spouse or with your kids, or maybe not with the kids, just to have that kind of a break. Or maybe it means just sort of getting away briefly just by yourself. That can be important too. But at the end of the day, given how hard physicians work in this country, 4 weeks is really a joke. That sort of, so I would agree with you. And then, you know, when and if then people have any kind of autonomy, that maybe then they can set their own vacation schedule. That maybe they've learned that isn't going to work for me. I'm going to have to be in a position where I can actually take more time. So, I mean, it's an example of paying attention to your own needs, and the other thing too that is kind of connected with this is the needs of others. Because you should know there's that long history of we physicians feeling awful if we're leaving a place short-staffed. You know, so there's only so many people can be on sick leave, for instance, at one time, or on mat leave, or paternal leave, or, you know, that sort of thing. So there's all of these moving targets that, you know, play a role too. So this is the kind of stuff that I think does need to be sort of looked at within various branches of medicine, as well as in medicine sort of systemically. So, any questions at all from those in training?
Just in terms of,
Yes.
because my impression, from what I understand, this is something that we're starting to see earlier and earlier, not just in postgraduate trainings, but even
In medical school?
as well. Aside from like substance abuse or even like previous history of depression, are there any other risk factors that we can sort of look for to identify individuals early that might be at a higher risk than other trainees?
You put your finger on something there that I hadn't really maybe emphasized enough. Possible sort of what we call pre-existing conditions. Somebody, for instance, who might have had a history of depression, anxiety, sort of PTSD, like in college or something like that, or in high school, okay, and could be at risk of having a relapse. So there's all of that, and same with substance use, especially if there's genetic loading, because we know a lot about that now. And I hope that any of you are following any of the profound research on drug addiction. As you know, it's such an it's the opiate issue, but it's a neuropsychiatric illness. I mean, the research that's going on at the NIH and the NIMH are really profound. And that explains just over again and over again why smart and good people can become absolutely, they lose their judgment, you know, with a severe addictive disorder in place. Okay, so I want to leave those preceded. The other things though is that we know now, because there have been studies of matriculating medical students, there are sort of health indices of how they compare with first, second, at the end of first, second, third year of medicine. And there are stuff where rates go up. So what the AAMC is looking at, and I was just in Washington over the summer giving it, they wanted me to speak specifically about medical student suicide, which I did, but I also wanted to talk about, you know, about the climate, the educational climate. So that's, because it's not just having resources for medical students. We have to make training less toxic, that sort of thing. And so the things that's being done there has a lot to do with the things that we're emphasizing in residency as well. A good orientation to the new rotation. I'm talking now clinical years. That's very important. It helps people a lot. Just a sense of feeling valued, that you are part of the team. Sure, you may be the lowest person on the team, but yet you're a valued member of this team. We welcome you, we want you here, you're the doctor of tomorrow, that sort of thing. Those kinds of things really, really help a lot. I mean, it's corny, but when people in authority make statements like, look, we're one big family here, you know, that sort of thing, those kinds of messaging is really, really very important. The way exams are scheduled, or the way, if they're not sort of spaced, and now there's all this emphasis on the step exams, of course, in medical school, that is causing a lot of anxiety in students. So, I mean, there's just so many things like that that really need to be looked at and examined, because it's not fair for the student, because see, any student who becomes ill sort of very quickly tends to sort of blame themselves. And they can get into what I call fraudulent thinking, and say, you know, I think they made a mistake letting me into medical school, that I'm taking up the place of somebody who's more worthy than I am, that sort of thing. They shouldn't have to have that kind of feeling. They feel less than very quickly, because they look around and it looks like everybody's coping pretty well. They may not be, because they're kind of isolated, that sort of thing. So again, just sort of more of these sort of health promoting strategies, the better. I always tell people to try, despite your busyness, to try to keep built in some of the things that are on that slide, especially the importance of exercise. You know, and those students who are really quite organized will make sure that they don't let that go, that sort of thing, despite a very busy schedule. So, you know, it gets incorporated.
I just have one other comment and question. Do you think, because, I mean, medical school and getting to medical school and into residency is a tremendous financial burden on the individual, that if you feel like you burn out in another profession, you would just get another job or work something else, whereas medical school, some of the residents are graduating have $300,000–400,000 in debt.
That's right.
So they're kind of enslaved to the system by now, and which might compound the entire problem.
And this one that is brought up really scares me, because it is. It's obscene. I mean, you people know, you're living it, the debt. And we know that it dictates sort of the branch of medicine, too, sometimes, that people go into. That people say, I'd love to go into that field, but it doesn't pay enough, that sort of thing. And that's just, you know, that's where I'd be seeing that sort of thing. So there's that. The other thing, too, about that has a lot to do with, I think it's more, I think sometimes we pay lip service to it. And because it's so common, everybody has it, blah, 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 so just kind of cope, use your defenses or whatever. But yet, you know, when people get down and they're not feeling well, I mean, I've seen it in just general patients where you can begin to have these ruminations about financial ruin. You know, I'll never get out of this hole, or I'll never be able to pay this off, or whatever. That's what I mean. It scares me as a psychiatrist that that's the type of stuff that could come together with a lot of other factors in this so-called, what we call perfect horrific storm, when individuals make that decision to end their life. Because it all feels so, pardon my language, fucking hopeless. So, and I just, I just don't want it to be that way, that sort of thing. So, I don't know how we can sort of get around that, but that's why I said, I think it's obscene. I mean, even our own medical school here, it's a state school. I don't know the exact figure of what the tuition is, but it's high. So, and as you know, I don't know if any of you are offshore medical school graduates, you know what that tuition is like. So I think when people really, really want to be a physician, you also need to know that there's a price. You pay a price. We're talking sort of mental health issues, but it's costly.
Any last comments? Dr. Tu?
You mentioned you're going to mention what factors you found are specific to emergency medicine physicians that you're trying to find out.
Yeah, I'm not an expert on that, but one of the things that I've learned just through some of my colleagues, and I don't know how that, where I lived and worked in Vancouver in Canada before. I worked at a downtown city hospital, much like Kings County or Bellevue or whatever. It was smaller, but that kind of hospital. But a lot of the emergency physician doctors there, though, had a second job in a community hospital, a smaller community hospital. And some of them were really quite funny, actually. They said that they liked to do that because they said to me, it's so nice to be able to work a full shift without a patient telling you to fuck off. I said, it's just really nice. So, I mean, it's a metaphor, right? But they're describing and putting their finger on the abuse. You people get abused, that sort of thing. So there's things like that. Also shift work. I know, and this was some flack because I was friendly with a sleep medicine specialist, and he would sometimes need to evaluate those doctors who could no longer do shift work because the way it was affecting their circadian rhythm and affecting their sleep-wake cycle as well as mood stability. And this has been studied in what we call treatment-resistant depression and in bipolar illness. So any physician that's living with one of those illnesses but yet is doing well, is a good patient, compliant with medication, psychotherapy, sometimes those individuals do not do well with change to their sleep-wake cycle, that sort of thing. Colleagues of doctors like that often were not very sympathetic that was an individual who, because of medical reasons, did not have to do shift work. But yet there was a biological argument for that, but sometimes people weren't very sympathetic. Those are just a couple of things that come to mind. But your hand was up, so maybe you have some
So I think
tips.
it's really important to honestly look inside yourself and choose the job that's going to fulfill you. And you may say, I want to be a champion and help the underserved. But when it comes down to the end of the day and you start doing that job and you're not happy and money is a better reward for you, then you've just lied to yourself and you've chosen a place where you're going to be unhappy and you're not going to feel fulfilled. I come to work here, I'm fulfilled, I like what I do. The money is not so important, but you have to be honest with yourself. And if you find that you're not happy with your choices in life, then you'll never be happy and it's going to compound the problems.
Thank you. I like stuff like that. Those are, sort of words of wisdom from the trenches. Folks, I better let you go. Okay, thank you very much.